I'm Janet Rodriguez, Administrative Director of the Resiliency and Wellbeing Center here at GW School of Medicine and Health Sciences. I'm pleased to welcome you to this SMHS Mental Health and Lifestyle Initiative talk. This is part of a continuing series of events sponsored jointly by the Center and the GW Lifestyle Medicine Clinic at the GW Medical Faculty Associates. Today's speaker is Dr. Vivek Jain. He is the director of the GW Center for Sleep Disorders, or the GW Sleep Center, as sometimes it's written. He is an associate professor of medicine in the Division of Pulmonary, Critical Care, and Sleep Medicine here at GW. Dr. Jain is a graduate of the All India Institute of Medical Sciences in New Delhi, India. He did his residency in internal medicine and fellowship in pulmonary and critical care medicine at the University of Missouri Hospital and Clinics in Columbia, Missouri. His research on various aspects of sleep disorders has been published in more than several dozen peer-reviewed scholarly journals and numerous books. He lectures nationally and internationally on the topics of obstructive sleep apnea and heart disease, and in his spare time, he appears on the GW Integrative Medicine podcast, so check those episodes out. Welcome, Dr. Jain.
Well, thank you, Janet, and thank you for inviting me. I was told by Dr. Frame that this will be kind of somewhat of an interactive session, as part of the Wellness and the Resiliency seminar series or webinar series. And my task today is to kind of give a taste to everyone about the association between sleep and mental health, and to start, what I plan to do is maybe give you a 15 to 20 minute, rundown in a kind of a very rapid sense because the topic is huge. And then kind of open it to the audience for any kind of questions or queries that they may have. So when we talk about sleep and mental health, and obviously it is a bi-directional relationship. What is more easily understood is that if somebody has a mental health issue such as anxiety or depression or bipolar disorder, they may have issues with different physiological functions, including sleep. Most of the time will manifest as difficulties falling asleep or staying asleep. What's less well understood in the general community and also among physicians is that sleep disorders themselves can either cause symptoms similar to a mental health disorder, or if somebody already has a mental health disorder, then that sleep disorder can exacerbate the symptoms of the underlying mental health disorder. So for example, if somebody has the more common sleep disorder that we see, which is sleep apnea, and it goes undiagnosed, and they also have depression or anxiety, then it's well known that if one does not manage the sleep apnea, then the symptoms of depression or anxiety may not be as well controlled. It also makes sense that if somebody has what we call as hypoactive depression, where the depression manifests more as feelings of fatigue and tiredness in the daytime, and symptoms of sleep apnea are similar to fatigue and sleepiness in the daytime, then there can be some confusion. Is it a lack of proper management of the underlying depression? Should I increase the antidepressant dose? Should I do psychotherapy? And that happens once in a while, and then we'll see those patients, we'll treat them for the sleep apnea, and definitely we'll see some better control and management of the underlying mood disorder. The other thing that we try to teach the patients who have a mental health disorder, which is, say, either depression or anxiety, is that lack of sleep itself, not insomnia, but just lack of total sleep hours, can also exacerbate the mood disorder. So if somebody's sleep deprived, whether it's due to lack of opportunity to sleep, whether it's due to voluntarily restricting sleep, whether it's due to a circadian rhythm disorder, shift work, jet lag, then during those situations, if I get less than the needed amount of sleep, then that can also exacerbate the manifestations of the underlying mental health condition. One example that we see that sometimes is in bipolar disorder, where the sleep deprivation can manifest as almost like exacerbation of the mania component of the bipolar disorder. So that's something that we share. Over the last 20 years that I've been at GW, certainly with the Department of Psychiatry and the sleep medicine, we share patients. We get a lot of referrals from the mental health clinic saying, patient has XYZ mental health disorder. We are managing the best of our capabilities, but maybe the patient has another, primary sleep condition. Is it okay to evaluate them and see if the treatment of the primary sleep condition can help us better manage the mood disorder? And we do that in conjunction with the colleagues in mental health. The other area that I want to touch upon is things like narcolepsy and idiopathic hypersomnia. So these are rare conditions, generally manifest with excessive sleepiness in the daytime, in spite of adequate amounts of sleep at night. Um, Need to take naps in the daytime. Generally, a condition of young people. So the symptoms start at a very early age. And not often, but rarely, they do get kind of misdiagnosed as childhood depression or attention deficit disorder. And it's much later on that people started realizing, oh, maybe this was a condition like narcolepsy or idiopathic hypersomnia that went undiagnosed. And certainly treating this condition can help or better manage things like childhood depression or ADHD disorders. It's rare for children to have sleep apnea, but it's becoming unfortunately more common given the prevalence of childhood obesity. So that's another thing that the pediatric colleagues will now start recognizing, that maybe the child doesn't have ADHD, maybe it has a primary sleep condition. As opposed to adults who have sleep apnea and manifest their symptoms with sleepiness in the daytime, it's well known that majority of the children with conditions like sleep apnea or say restless legs or periodic limb movement disorder, instead of manifesting symptoms of sleepiness in the daytime, they actually have symptoms akin to attention deficit or hyperactivity disorder. And so that's another area of overlap that is now well recognized, and treatment of one condition can lead to better outcomes. One can imagine that if somebody has been suffering from things like narcolepsy or idiopathic hypersomnia, which has not gone diagnosed, and they're falling asleep in classrooms, and they may be labeled as being lazy, and that may lead to secondary, bad outcomes. I'm getting a question, so just give me a second. I'm just going to read this question that Jeanette posed in there. Could you put some focus on how healthcare providers can help themselves to or get help for sleep conditions that affect mental health? Yeah, so certainly if you are, again, idea is that if you're recognizing these symptoms, um, uh, you know, uh, of mental health condition, whether it's feelings of depression or anxiety, but you also have additional symptoms suggesting a primary sleep condition, whether it be sleep apnea or perhaps undiagnosed narcolepsy or idiopathic hypersomnia, then do absolutely come and see us for a consult. You'll require a sleep study to see what's going on, but what you can do at home, even before you come in for a sleep evaluation to the clinic or to the lab, is focus on things like, let me just close this message here, things on sleep hygiene or avoidance of sleep deprivation. So, very quickly, the things and tips that I give patients is that, we all roughly can guesstimate how much sleep we need per night. So most people need 7 to 8 hours. And one of the very common social scenarios is during our work days, we cheat on sleep involuntarily or voluntarily and get 6 or less hours of sleep sometimes. And then we try to make up on the weekends. And one thing that sleep physiology has understood very clearly is that kind of a formula does not work. If I need 7, 8 hours of sleep at night, but tonight I get 6, then I got a deficit of 1 to 2 hours. I should make up that deficit in the next 24 to 48 hours. So next night I can sleep an extra hour. And if I had a 2-hour deficit, then the next 2 nights I should sleep for an extra hour on each night. So up to 48 hours is what I get to make up on my deficit. If I accumulate a deficit and try to catch up on the weekend, unfortunately, it does not work in the full sense. Sleep hygiene is equally important. So, think about, one of the things physiological principles underlying all mental health conditions in general. Again, these are very big general, this is nothing specific, but think about it as a condition of hyperarousability. So we all have a pathway, located in our brainstem that is arousing us. It has different neurotransmitters that allow me to respond to things that are happening in the external or the internal environment, which then let me become aware of that thing, and so I can respond to it. Also, similar to what you've heard, like the flight and fight response. Now, one of the things that happens in sleep is that this pathway that is coming up the brainstem and reaching my brain is shut off. So it's as if the gates have closed to prevent that from happening, so that I can sleep. Now, the gates don't remain closed throughout the night. There are, even just normally we'll have that gate open once in a while in the middle of the night, and we'll all wake up. We'll kind of understand what's going on. It's important to have those gates still be openable in case, I have a little shoulder pain and I need to shift my position. So I do that subconsciously or almost in my sleep. But what happens in a lot of mental health disorders is that gates become more easily openable. And the amount of stimulus that is needed to open those gates is much lower. And the amount of time that those gates remain open is much longer. So the idea is that the system becomes hyper arousable, and that is one of the reasons that causes more sleep disturbance, in terms of more awakenings, difficulty falling asleep because I couldn't close those gates, or I found those gates to just keep opening, and so I'm easily aroused. Now, what are the things that I do to my own self that makes that gate more easily openable? Is simple things like bad sleep hygiene, things like being in front of electronics at bedtime. So that has been well known to lower the threshold for those gates to open. So it causes more hyperarousability. So what can I do to improve my sleep? Is to you know uh, not be in front of things like electronics at bedtime, or at least 20-30 minutes prior to bedtime. Now, the general number is 20-30 minutes. Now, there are people who require longer periods of time to de-arouse themselves. So they need to start shutting off things much earlier sometimes. Some people are unfortunately not susceptible to arousability from electronics. And so, you'll say, oh, my friend can, have a phone in the bed and still fall asleep and have no problems. Each person is different. And obviously mental health conditions, make us more vulnerable to these, poor sleep hygiene things. Eating late, if I eat and I've eaten within 2-3 hours of bedtime, then that itself can be a source of arousability. Nicotine, alcohol can cause arousal. People think of alcohol as causing de-arousal, like sedating me, but that's a myth, because alcohol actually has a very short half-life, and once it dissociates from the receptors in the brain, it actually causes a rebound arousability. And so it's well known that alcohol disturbs sleep continuity and quality. If I have sleep apnea, then obviously the alcohol will make it even worse. Not having, it sounds trivial, but regularity of sleep rhythms is important, and you know variability of sleep rhythms can be a source of arousability, or lowering of the threshold of the arousability. So if I go to bed 11 p.m. on a weekday night, but on the weekends I watch a movie till 2 a.m. and then I go to sleep, or I go out with friends, that disturbs the circadian synchrony in my in the brain, just lowering the threshold for arousability. Primary sleep conditions, again, very commonly lower sleep arousability. So restless legs, sleep apnea, themselves are a source for arousing the brain. And so now you're adding another source that makes my brain not get good continuous sleep. And so again, idea is that if I suspect that, or you suspect that, then come to us, and we can find out if that's another source for loss of sleep continuity and sleep disruptions. Obviously, physical conditions like acid reflux or asthma or bladder issues can also cause arousability, and so obviously they need to be addressed as well. So roughly, if one has to take things in toto, that the mental health issue needs to be addressed by the person who's specializing in mental health. But if there's anything in addition to that, one can do at home. Obviously have good routines in terms of what time I go to bed, avoid caffeine, nicotine, alcohol, practice good sleep hygiene, maintain a cool, dark, quiet bedroom environment, avoid eating within 2, 3 hours of bedtime. Exercise used to be a thing that we used to tell patients to avoid within, like certainly 30 minutes to 60 minutes before bedtime. But now it's well known that any exercise at any time, even 5 minutes before bedtime, can actually improve sleep quality. Um, so, so practicing good sleep hygiene. If there's any suspicion for any primary sleep condition, absolutely come to us and diagnose and treat it, because that will help better manage the mental health condition. So, it's been 16 minutes. So I'm going to stop here and see if there are any pressing questions, because like I said, this topic can be huge. And I just wanted to give a broad brush as to how one can think of the association between sleep and mental health in a bidirectional sense. So I'm open to any questions.
You can type your questions in the chat, or you can unmute yourself, because we have, I think, a small enough group that would work.
The other thing I wanted to point out, again, this, unless somebody has a question, go ahead. If somebody has a question, yeah. So one of the reasons why we talk about this regularity of sleep-wake schedules is somewhat dependent on what time we start a morning exposure to light. So another very interesting thing in sleep medicine that's been found is there's a very strong correlation between people who are night owls and those who and symptoms of depression. And we used to think that if I can, there's strong correlation. The question is, why is that strong correlation there? Is because you can imagine a night owl, they prefer waking up, say, at 10 o'clock in the morning and starting their light exposure after 10 o'clock. But even in this, in the wintertime, the sun comes up, say, by 9 o'clock. So these night owls are missing on 1 hour of light exposure in the morning. And in the summertime, they're missing 3, 4, 5 hours of light exposure in the morning. And that is not good for our mental health. Some of us can manage it, but we see a lot of patients who are night owls also have been diagnosed with depression, and the same principles apply to seasonal affective disorders. So why is there more incidence of depression in the wintertime? Is again because the amount of light exposure that we have is much less than what we have during the summer months. So now there are a bunch of questions. So let me address those. So how can we help a gate to close? So obviously, the shortest answer to that is something called cognitive behavioral therapy. So if I have a mental health condition that is causing me to be hyper aroused or hyper arousable, and my gate keeps closing and it refuses to either shut, so I have difficulty falling asleep, or it opens very easily in the middle of the night and then I'm up and it then refuses to close, so I'm up in the middle of the night for hours. So I guess the question is, like, how can I learn to do that? So the idea really is that if I don't, and it sounds very simplistic, if I tell the patient, don't worry about the fact that the gate is opening, because the gate is opening because of the underlying mental health condition. But now if you worry about the fact that the gate is opening itself is going to make the gate more easily openable. So stop worrying about that gate. So how can you, so simple things we give, and I know it's a short, we have only 5 minutes or 10 minutes, but idea is go to bed only when you're sleepy. Don't worry about sleep. So at night, don't just look at the clock and say it's 10 o'clock, let me go to sleep because I have to get up at 5 in the morning. No. If you start doing that and you're not even ready for the gates to close, then the gates are going to remain open. You're going to get frustrated. You're going to go in bed. You're going to lay awake. Then you'll start looking at the clock. Then looking at the clock is going to make you more frustrated. That emotional surge is going to make the gates more open or less likely to close. So I tell patients, only go to bed when you're sleepy, but maintain the same time to wake up in the morning, no matter how late you went to sleep or how early you went to sleep. And once you fall asleep, if you do happen to wake up in the night, your first instinct should not be to look at the clock and say, hey, what time is it? Because that's going to make the gates open even more, So this kind of a cognitive behavioral therapy, in addition to good sleep hygiene, which is, the things that I mentioned, will over time make the patient learn how either to close the gates or not be bothered by the open gates, which will itself make the gates more easily closable. And that'll help. How to fight jet lag during travel? Any suggestions? No, that's a toughie, because unfortunately, you know, yeah, so the best, most physiological answer to jet lag travel is that if I know that I'm going to be traveling to a zone which is, say, from here to Europe, so London is 5 hours time difference. So if I know that I'm going to be traveling to Europe, which is 5 hours ahead of us, and I have to start, you know, advancing my circadian rhythm to wake up earlier and go to bed earlier, then I should start practicing that in DC before I fly to London. And it's one night for every time zone change. So I should start doing that 5 days ahead of time by just advancing my clock 1 hour each day. But that's unfortunately impractical. Um, and so uh, what one has to realize is, how do I advance my clock after I reach London? Um, so I should aim to reach London in the morning hours and then try to remain awake the whole day and not take a nap. And if I build my sleep deficit by just remaining awake, then I can try to. It's easier to adjust the clock. Um, Same thing, I should try to avoid things like alcohol on the plane while traveling to London. Alcohol makes it harder to adjust to circadian rhythms. Hydrate myself in the plane. Sleep in the plane if possible. Sometimes I advise patients to take a little melatonin, not Ambien like medications, because those can have other side effects. But if you want to sleep on the plane, something like melatonin should be okay. Don't watch all the entertainment on the plane going from here to London. Uh, One thing with jet lag is that it's much easier to travel west than east because our tendency for the body is to delay our rhythm more easily. So traveling west becomes much easier for us, and adjusting to the clock, say on the California coast, as opposed to say Europe. So that's one thing. The other question is, for those who wake up on their own after about 6 hours, how do you recommend they hit the recommended 7 to 8 hours? So one thing there to recognize is, am I just a 6 hour sleeper? Not everybody needs 7 to 8 hours. So there are so-called natural short sleepers, who need only 6 hours, 6.5 hours of sleep at night, and they feel fully functional. Um, so if I am falling asleep and getting up 6 hours later but feeling fine, then it's okay. Then I don't need to be worried about getting 7 to 8 hours of sleep. But if I know that I feel better when I sleep 7, 8 hours, and all of a sudden I've started waking up too early, before my desired time to wake up, then there are several things that one should look at, because one common thing is sleep apnea. Sleep apnea tends to get worse in the latter half of the night, and that can cause early awakening. Alcohol is a big reason for early awakening. Depression is a very common reason for early awakening. Um, Circadian rhythm disorders. So with aging, we become morning people, most of us, not all of us. And sometimes as we get older, we don't recognize that my morning wake up time is shifting to an earlier time. So where I used to wake up at 6 a.m., and now all of a sudden I suddenly realize, oh gosh, I get up at 5. What I have to then recognize is that maybe my bedtime should also advance a little bit. So, I used to go to bed at 9 or 10 and wake up at 6. And now all of a sudden I'm getting up at 5. I have to recognize maybe I'm starting to feel sleepy at 9, but I'm just postponing my sleep because, I'm with family, I'm watching something, or I'm eating, or I'm out with friends, or just reading a book, and I'm saying, no, 9 is too early. I have to push myself to stay awake till 10. So I see that a lot of times with advancing age, people will come to us and say, "Hey, I've started waking up too early," and I say, "Hey, have you tried going to bed early?" So I hope that answers that question. Um, I know sometimes, I'm answering these questions in a bit of a hurry. So if there's any like a follow-up comment or further query, please ask that either verbally or through the chat. Again, interesting tidbits that I can share with people, because sleep and mental health is an important issue. Is again, light at night will tend to delay our circadian rhythm. In addition to just causing poor sleep quality, independent of anything else, if I have a tendency to be a night owl, then any exposure to light at night is going to just push me in the wrong direction. Uh, Alcohol suppresses our natural melatonin, so that's another way alcohol disrupts sleep, is by suppressing melatonin. So I've had patients who take melatonin for sleep purposes or advancement of circadian rhythm purposes or whatever, and in addition, they sometimes drink alcohol, and so they wonder why it's not working, because literally alcohol will chew up melatonin and negate all the effects that I may have from melatonin. Uh, One thing which is a myth is that you know so if I just ask the simple question to any public forum and say, listen, how many people in this community have difficulty falling asleep and staying asleep? You know, and you people are surprised that if I just the answer to the general question is, 33% of the population does not get a picture perfect night sleep every night. I mean, majority of the people, a third of the population, will have difficulty falling asleep and staying asleep, at night. But only about 10 to 15% of the population really has what we call as an insomnia disorder. So it's not just the difficulty falling asleep and staying asleep that defines insomnia. It's what are the consequences of that? Am I concerned about it? Is it affecting me how I function in the daytime? That's what creates a disorder. And so one simple technique or a tip I give people and patients is that just because you're not able to fall asleep or stay asleep on one given night, don't get concerned about it. And two, if that sleep disturbance, the difficulty falling asleep and staying asleep is because of gates being open, or me being anxious, or me having depression or a mood disorder, then just by treating the sleep condition by giving me Ambien or giving myself a sleeping aid is not going to help the underlying root cause of the problem, which is the depression and the anxiety. And so just relying on a medication alone is never going to be a solution to the underlying mental health condition. We have approximately 3 minutes left. Any other pressing questions? Well, I thank you for your time, and Janet and Dr. Frame and Dr. Kogan.
Thank you, Dr. Jain. If you're interested in more of what Dr. Jain has to say about sleep, whole health, well-being, please click on the Sung Symposium link that I put in the chat. He was among the speakers for the event that went from everything from what he just spoke to, and then even deeper into the science of sleep, if you're into that type of thing. So thank you all very much for being here with us. We hope that you'll continue to follow us and this new initiative that is here for you. All right, take care, everyone. Have a great weekend.
Thanks, everyone.